Hi, welcome to the November Cancer Prevention Wellness Series presented by the Cancer Survivors Park Alliance. We are here with Dr. Megan Scharf, who is a dermatologist at Carolina Dermatology here in Greenville. Dr. Scharf did her medical training and residency at Vanderbilt Medical Center, and we are happy to have her on the call today to discuss cancer prevention and awareness for skin cancer.
Hi. Thanks, Rachel. So my talk today is called Deeper Than the Surface, Skin Cancer Prevention and Awareness. And obviously this is something that I'm very passionate about. And thank you for giving me the opportunity to come and, or not come, but to present online and go through my slides here. Because it really is skin cancer is a very important topic because it's estimated that about 20% of Americans, so 1 in 5, will develop basal cell or squamous cell carcinoma in their lifetime. So it's a very, very prevalent issue and something that obviously we feel very passionate about and think it's very important for people to know what to look for. And that we'll kind of go through that and then talk about what to do, how they're treated, and then sort of talk at the end about some of the guidelines for screening and then prevention. Because there are things that we can do if things like this are caught in the early stages. They're very treatable and people do very well. But things that are not caught early and, sort of similar with lots of different types of cancer, but, early detection is the key to good outcome is what we say a lot of the time. So we'll talk about what can be done by patients at home as far as, doing self skin checks, coming here to the dermatology office for us to do skin checks and sort of what to look for as far as what's a problem and what you need to call and have looked at. Because again, it is a very prevalent issue and something that we want to try to catch early. So this is just a little diagram of the skin. And most of the skin cancers that are the more common type come from this epidermal layer. That's the top layer of your skin. And then underneath there's the dermis and then the hypodermis, which is where the fat is. But the epidermal layer is where the majority of the skin cancers come from. And we'll kind of talk a little bit more specifically about the squamous cells and the basal cells. So in your epidermis, there's squamous cells that are on the top, and then your basal layer is lined by what are called basal cells. Kind of makes sense. And when you have a basal cell skin cancer, that originates from those basal cells. And so people a lot of times will ask, if I have a basal cell, can it turn into melanoma? And the good news there is that does not happen because it has to do with the type of cell that is turning or transforming into cancer. In this little diagram here, the red cells are the melanocytes. And so there are fewer of them in the basal layer of the skin, but they do sort of reside in that bottom layer. And then they have little branches that kind of branch out to transfer the melanosomes, which is where the pigment is, because melanocytes are the cells that make pigment in our skin. And so there are just fewer of them along that bottom layer. And then the squamous cells, again, are like the top that make up the majority of the epidermal layer. So any one of those three can transform and become a skin cancer, but they don't sort of cross over for the most part. And so, again, these are the most common types of skin cancer that we see. There are lots of different cells that are in the dermis and in the hypodermis, and they can, any cell that you have can turn into a cancer. But the most common skin cancers that we are dealing with are basal cell, squamous cell, and then melanoma. And melanoma, if you look at the little diagram, is the one that's the more dangerous of the three. Basal cell and squamous cells are luckily much less aggressive, less likely to cause problems, spread, that type of thing, but still something that we want to catch in the early phases. So we'll talk about kind of what to look for and what to do in the following slides.
And awesome. Real quick, are all of them environmentally caused, or is there some genetic predisposition or familiar
Yeah.
predisposition that somebody can have?
Yes. So that is a very good question. And the vast majority of skin cancers come from or originate from UV exposure. So sunlight, sunburns, that type of thing. But there are definitely genetic syndromes and genetic mutations that people can inherit that are familial that can predispose you to developing basal cells or squamous cells or melanoma. And we'll talk about that in like the subsequent slides. But a lot of times with the risk factors for basal cell and squamous cell that we'll run into, the traits with like having fairer skin, lighter color hair, lighter color eyes, that is a risk factor for developing basal cell and squamous cell. And certainly that is genetic. And so, and then the other thing that isn't really genetic, but is more familial are people's sort of lifestyle habits. So, do you live at the beach? Is your family, active outside a lot of the time? So it's not necessarily like the genetics of a skin cancer mutation that is inherited, but it's more your predisposition that you inherit from your parents. So having family history of basal cell and squamous cell, does probably mean that you have a little bit of a higher risk just because of, again, like your parents had lighter skin and you have lighter skin, or like I said, you lived out at the beach your whole life, that kind of a thing. That those types of things we see as more familial. That's like more common. Now, melanoma, about 10% of melanomas are familial. So that means 90% aren't. And again, some of that has to do with like being something where you inherit the like the skin traits that make you predisposed to having melanoma. But there are some genetic mutations that you can inherit that do predispose you to melanoma, and we'll kind of talk about those at the end specifically.
Awesome. Thank you.
Question. And then the other thing that happens a lot of times is they'll hear, oh, my, uncle and my grandfather had a skin cancer. And so, it does, like, just when you hear skin cancer, again, with basal cell and squamous cell, they're far more common than melanoma. So a lot of times that's what that was. But certainly, it's still good to know that, it's a little bit different, than melanoma, and people, sometimes have not a problem, but sometimes people get confused because they hear skin cancer and they automatically think melanoma. But a lot of times that's not the case. So that's good. So basal cell carcinoma. This is a picture of a basal cell. That's a very enlarged picture of a basal cell. But you can see it's kind of like a pink shiny bump that maybe has a little like scabbing on it. And you can kind of see the little blood vessels a little bit better if you look closely kind of in the middle. But that's what basal cell carcinoma looks like. And it is the most common cancer in the entire world. So again, this is like a super, super common problem that we want people to be aware of like what to look for and what to come in for. It compromises about 80% of all non-melanoma skin cancers, and roughly 2.8 million are diagnosed every year just in the United States. So it's very, very common. And when cancer statistics are done, a lot of times basal cell is not really included in those numbers because the mortality rate is very rare. It is extraordinarily rare that basal cell would lead to somebody's death. There is an increased risk, though, that if you have a basal cell, that you are at higher risk to get another basal cell. And so that's about a 40% increased risk. And then men are more commonly affected than women, an about 2-to-1 ratio. The risk factors for basal cell are intermittent intense sun exposure. And so this is like sunburns, like if you remember, like, oh, I had this horrible blistering sunburn when I was 10 years old and sheets of skin were peeling off. That is that type of like basal cell carcinoma risk factor. And so again, people with fair skin who always burn have that higher risk. And that's, again, the type of your skin type is what is inherited from your parents. And so people with red hair, blue eyes, freckling, are higher risk just because you're higher risk for having had the sunburns. And then another interesting thing that does put you at higher risk is people who are immune suppressed. So people with organ transplants, people on long-term prednisone for things like autoimmune disease, that type of thing. Immune suppression really puts you at risk for all types of skin cancers, but it's your immune system plays a very important role in surveying your body for precancer cells. And so I tell people a lot of times that, if your immune system can't adequately address and get rid of precancerous changes because your immune system is suppressed, then small precancer changes that typically would be taken care of by your body can progress on to become basal cell, squamous cell, that type of thing. So that's an important risk factor. And for the most part, people who are immune suppressed with organ transplants, the transplant teams are very good at saying, hey, you need to go get your skin check at least once a year. Sometimes we'll see those folks on a 6-month basis. But that is a very important risk factor to be aware of if you're immune suppressed. And then again, people who are on things like long-term prednisone, some of the immune suppression things for autoimmune disease, Humira is a specific one that just comes to mind, that puts you at higher risk for things like melanoma. So if you are immune suppressed, you should probably be getting a skin check and protecting your skin from the sun, which we'll talk about. Mm-hmm. And so what do basal cells look like? What should we be looking for? A lot of times they're just like skin color bumps, and they're not pigmented for the most part. They can be pigmented, but they'll have this like shiny, kind of pinkish pearly appearance. Again, sometimes you can see the blood vessels more inside of them, and that sort of goes back to that first picture, but sometimes not. And sometimes they'll even ulcerate and bleed. And in these two pictures, you can kind of see where there's like a scabby crust in the middle of them. And then the face is a common place because obviously your face is most exposed to the sun, and people, have those like blistering, peeling sunburns on their nose when they were a kid. And that's a common place that basal cells can show up. So if you get something, you're like, oh, I have this weird pimple and it's like not getting better. Then that could be something to have evaluated. Bleeding is a sign that I tell people if you have a pimple that keeps bleeding, then that's something to have looked at as well. So that's kind of what you should be looking for. And again, it typically presents as like a wound or something that just like won't heal. And it's a really common story for a patient to come in and say, hey, doc, I have this place in my face and it's like a weird acne bump, but it won't heal. So I put some Neosporin on it and then it almost healed. And then a few weeks later, I woke up and, oh man, it's bleeding. And like they'll bleed in the night and they'll wake up and there'll be blood on the pillow. And so if you just keep having this spot that like keeps not getting better, that's something to have looked at. And that I tell people this a lot too, that they're kind of like a cavity. They're technically, yes, it's a cancer, but they will continue to be locally aggressive and they'll spread. And certainly you want to catch them when they're smaller because it's less that has to be removed. But as long as you get those bad cells out, then they don't spread to your lymph nodes or that kind of a thing, unless you have some sort of more genetic predisposition, which again we'll talk about. But they can be locally aggressive and they can track down nerves. They can track down your optic nerve if they're on your face, but they don't spread sort of distant metastasis. So, something that you want to get it out and get all the bad cells gone. But they're sort of what we talked about at the beginning. They're very unlikely to cause, metastasis and death. So something that you want to have taken care of. And then there are different subtypes of basal cell. This is sort of just a histologic picture. They can be nodular, superficial. If they're infiltrative or morpheoform, those can be a little bit harder to clear. And so what you do as far as treatment with those is there's a procedure called Mohs surgery, and we'll kind of get into that after we talk about squamous cell, because squamous cell is another thing that you can treat with Mohs surgery. But depending on the subtype, it sort of depends on like what we do to treat these things. And so squamous cell skin cancers, this is two pictures of squamous cell. They tend to be more like scaly, rough patches. And they can sometimes be painful. And it'll be like, oh, I have this little scabby place that's like not getting better. And sometimes I tell people, like, if you have something and it feels like there's a piece of glass sticking in your skin, it can be like a sharp, stabby pain sometimes. That can be squamous cell. So squamous cells are the second most common cancer in the world, and they make up about 20 to 25% of all non-melanoma skin cancers, and about 0.7 million cases are diagnosed per year, with men being more commonly affected than women, again. And then these are like once you get over the age of 60, like significantly increases the incidence of squamous cell. Again, mortality is very rare. Only about 5% of cases spread to lymph nodes. Again, if you catch them early, easily treatable, but do have a little bit higher risk than basal cell for spread. And it's important to know, very different than lung squamous cell carcinoma. If you start looking up squamous cell and you get talking about lung squamous cell, like that's a whole different thing. But skin squamous cell carcinoma, very low mortality rates, and easily treated again if you catch things in the early stages. And luckily for skin cancers in general, with skin cancer, like you're able to survey your skin, and that's it's a pretty easy non-invasive thing to have somebody like just look over your skin. And so we are able to identify and catch things in the early stages a lot of the time, which is probably why the mortality rate is much lower for these things, because we do catch them early most of the time. So, but it's good to be aware of like what to look for.
Yeah, and can you just explain the men versus women ratio you had there?
Yeah.
And why you
So
feel there might be a reason
yes,
for that?
so that's probably related to just like sun protection habits for the most part, and
Okay.
occupation. So
Okay.
that's another thing with you know I, I I I don't think that it's anything specific more than that.
Mm-hmm.
But I think it's just that, and plus for men specifically, the scalp is a common place that men get a lot of squamous cells. Just and the top of your head is like always exposed, and
Yeah.
men, especially if you're not wearing a hat, tend to get squamous cells on the top of their head. So that's probably has something to do with that. Because with squamous cell, it's more cumulative long-term sun exposure. So it's not like as much oh, I had a really bad blistering sunburn when I was a teenager. It's like every day you're outside, doing your thing, and you're getting
Yeah.
sun exposure like over the years. Sunburns and things like that do contribute, but it's more the cumulative sun over your lifetime.
Okay.
And then again, fair skin, the red hair, blue eyes, freckling.
Mhm.
You can also get squamous cell in areas that you have like chronic trauma. And so sometimes what people will come in and they'll say, oh, well, I bumped my head, on the attic thing. And so that's just a place where I bumped my head, but it like still isn't healing. And
Mm.
that will have been, 2 years ago. And they're like, well, that's where I bumped my head. And I'm like, well, if it's been 2 years and it's not getting better,
Yeah.
then that's something that needs to be looked at. And same thing happens lower legs. A lot of times will become like wounds that have a longer healing time. And the thing I explain to people with that is like, you have skin cells that are like trying to heal and they're proliferating. And one of those cells will kind of get triggered into, because as it's multiplying, as it's trying to heal, like a genetic or mutation will happen, and then all of a sudden it's a skin cancer. And so just because it's an area where you had a wound or a trauma, like don't write that off if you feel like it's something that's not getting better.
Mm.
So, chronic wounds that just like aren't healing, that can be skin cancer. Even if you're like, I am sure that this was a place where I got scratched by a stick, 8
Yeah.
months ago or whatever.
Right.
So, and then again with organ transplants, it's interesting because organ transplant recipients have a switched incidence rate. So it makes squamous cell even more likely than basal cell if you have had an organ transplant, and that immune suppression plays a larger role in the development of squamous cells. So it is something, again, just to be aware of, like places that don't heal. You can kind of see on this picture where there's like these scabby places that like aren't getting better. And so if you have something like that, that's like just sort of like a chronic scab,
Mhm.
that's something that probably needs to be looked at. So I tell people typically, after like a month or two, if things aren't getting better, like that's about the time frame to call. Sometimes people get a little excited and they call and it's been there for 3 days, and they come in and we're
Yeah.
like, well, like maybe that'll still get better. We can just kind of keep an
Mhm.
eye on it. But
Okay.
it's been 2 months, like you need to have it checked.
And real quick, what
Yeah.
makes squamous cell more dangerous than basal?
So squamous cells have the propensity or ability, rather, I guess I should say, to spread to your lymph nodes, whereas
Okay.
basal cells don't do that.
Okay,
Um,
so it can metastasize and
yes,
basal
yes,
can.
yes,
Okay.
yeah. And I think I said back here it was like about 5% is sort of the
Yes.
number that's given, and that tends to be ones that are ignored for a long time, where you'll
Right.
be like, oh, this has been here 10 years and it's like still not getting better. Certainly there are some more like aggressive subtypes that can arise, but it's rare, but it can happen. um, so um, let's see. So what to look for most commonly, on places that are sun exposed. So scalp, like I was saying,
Yeah.
face, neck, forearms, hands, and then your like anterior lower leg, your shin. They're usually like reddish pink, maybe skin colored, but they have like a hard lump on them sometimes, where you'll like feel over it. And sometimes the people think like, oh, I have this like funny cyst under my skin. But again, with that pain where you're like, ooh, like that's a sharp, stabby pain, that can mean that there's squamous cell underneath. Um, and really, it's the ones that are like rapidly growing that are like a little bit more of a concern. But they can grow slow or they can grow fast. And then they can come on your lip. You can see in that one picture that's a man's lip, there. And then the one here by that man's ear, but it's typically
Yeah.
sun exposed. Um, and again, some with basal cell is just a spot that doesn't heal. Um, their vast majority are easily treatable. Small subset can spread to lymph nodes. And the ones that are rapidly growing, or the lip and the ear are higher risk areas for spreading to lymph nodes. So if you have like a sore on your lip that's like not getting better, that probably needs to be evaluated. And then let's see. Oh yeah. So then there's different subtypes here as well. There is something called squamous cell in situ. And in situ is a word that means in place. So it's only in the epidermal layer. So technically not invasive down through that epidermal layer into the dermis. Because in the dermis is where you have like your blood vessels, your lymphatic vessels, your nerves. And so once things invade down to the dermal layer, that's when they have access to the lymphatic vessels and they can spread. And so in situ doesn't have that. It's only top layer. So they're less dangerous, which is good. And then with the differentiation, so that has to do with like what do the cells look like under the microscope, and how much do they look like a regular squamous cell, or how bad are they, and they're rapidly dividing, they don't have time to like become a full squamous cell under, when you look under the microscope, they're just so rapidly spreading that, or dividing, that they can break off and spread. And that has this well differentiated, moderately differentiated, poorly differentiated, has to do with like what does that look like when you look under the microscope. And the poorly differentiated ones are more likely to spread, more dangerous. So that's an important thing to consider when you're looking at the pathology report. Like, does it say well differentiated? And those are like not as dangerous, or is it poorly differentiated or mildly differentiated? In which case, those might be ones that are like a little more aggressive. There is a certain subtype of squamous cell that's an interesting one. It's called a keratoacanthoma. And those will look like little volcanoes that like grow up onto your skin, and they can come very, very quickly, but they are typically not dangerous. They can spread, but it's very rare. And I tell people you kind of think of them as like growing up and out rather than down and in the skin. And so it'll be like this little like mound that comes up. They can be painful, but usually when they're like growing off, and it'll like have this little like sort of core that looks like, in some of the pictures you could kind of see how they do that, where it's like this, they're growing up and it's like a little volcano. And so that's like a certain subtype of squamous cell that's actually less dangerous. And then there is an overlap that's called basosquamous cell carcinoma. And basosquamous cells are a little bit more aggressive. They like kind of can't decide what they want to do. And so it's like both mixed together. And those can be more likely to spread. So again, sort of the subtype determines what do we do about it. And so as far as treating basal cell and squamous cell, a lot of it depends on where it is, and again, sort of what that subtype was. When you have them on your head and neck, usually we'll do Mohs surgery. And so Mohs surgery, we'll kind of talk about in a couple slides, but it's named after the doctor that came up with this technique to examine all the tissue margin. And there's a little diagram about that. But when you have your head and neck skin cancers, there's not a lot of margin to take when you have something that's next to your eyelid, and you don't want to cut into where it's going to become like a functional issue for your eyelid, so they take a very small margin. And so that's a way, the Mohs surgery, to kind of keep the margin small but able to evaluate all of the margin and make sure you get it out. Other things are just a wide local excision. There's a thing called electrodesiccation and curettage that we'll talk about. That's a good option for some of these more superficial types. And sometimes you can even treat with creams, and we'll kind of talk about when that's appropriate. And then very rarely, people who cannot undergo surgery for whatever reason, you can do radiation treatments as well. And the very good thing about these is most of the time they're in-office procedures, and they just require local numbing medicine. I tell people you'll come in, we'll numb it up, we'll chat, we'll listen to some music, and then you're on your way in about 20 or 30 minutes. So this is the diagram about the Mohs surgery. And it kind of goes through the way that they kind of take the layers. And this is the thing where, again, you're trying to spare taking a large margin around. And so you're able to take a very thin first layer and look at all of the edges of that tissue under the microscope. And typically those slides are prepared while the patient is in the office waiting. So we tell people there's waiting time, bring a book, bring a snack, because you're just sitting around waiting for the tissue to be made into slides. And then the Mohs surgeon will look at that under the microscope, and they map it out so that they can see, well, there was a root on the 12 o'clock side, and there's more going there. So we need to go back to that specific area and take more. But, 3 o'clock to 9 o'clock is clear. And so you don't have to take any more on that area. So you're able to, and then they'll go back and they take more at the 12 o'clock space. And then they look at that under the microscope, and they keep going until they see like all the margins are clear. But again, without having to take like extra more than necessary, I guess is. And so it's a great way. It's called tissue sparing. So they don't take any more than they really have to get it all out. And then wide local excision is something where, like, if something on your arm or your back where there's a little bit of extra tissue that it's not as important for the tissue sparing, and you take a standard margin around the skin cancer, cut that out, suture it closed, that gets sent off and they check it under the microscope, and then you get a phone call in a week that says, hey, good news, we got it all out. And so there's standard margins for basal cell and squamous cell. Usually it's 4 to 5 millimeters. For melanoma, usually it's around 1 centimeter. So it's a larger area around if you have melanoma. And we'll talk about that in a minute. But the cure rates for wide local excision, it's very good. It's 97%. So that's what we'll do if it's not like on the face.
Do you have to come back after that, or is that?
Yeah, so that's a good question. So follow up for skin cancer. So if you get diagnosed and you have a basal cell or squamous cell, and you come in and you have it treated, as far as like what to do after that, like a lot of times we'll have people come back in 6 months to do a 6-month skin check. Because again, if you remember from one of the first slides about basal cell, once you've had one basal cell, your risk for another basal cell is about 40% increased. So you typically will come back in 6 months and we'll just do a full body skin check, because you never know like where things can pop up.
Right.
And depending on sort of like how many precancerous things are there and what we're finding, and sometimes after 6 months, if you come back and you're clear, then we'll go to annual visits. But it is a good idea, especially if you have had a personal history of skin cancer, to come once a year, because again, early detection is the way to get good outcomes. And a lot of times what happens is people will come in and they'll say, oh, I got this big thing here. And we're like, oh, no, it's not that thing. It's this little thing over here that like you didn't see yet. That's the problem. And so coming in for like a regular skin exam when you've had skin cancer in the past is good. But typically, if you've had a skin cancer, 6 months to annual follow-up is what tends to be like a good time frame. Sometimes it's more than that. With melanoma, which we'll talk about, usually for those folks, we'll see you back every 3 months for at least the first year, sometimes 2 years, depending on how many moles there are, what we're looking at, what else we've found. And a lot of that is to monitor the melanoma that was taken, but then also to make sure that there's not another melanoma that you're gonna, not see if you don't do the close follow-ups. And again, we'll talk a little bit more in depth about the melanoma. And then for basal cell and squamous cell, another option for treatment is this electrodesiccation and curettage, or the scrape and burn. It's interesting when you have skin cancer, particularly basal cell and squamous cell, that if you're scraping it away, it curettes out because the skin cancer tissue is more friable, is what they call it. And you can tell when you get down to the normal tissue when you're scraping, because it has a different sort of feel. And so this is something that we do for ones that are, again, superficial. So the types that are good for this are the superficial basal cell, the in situ squamous cell that talked about how it's like only in that epidermal layer. Sometimes the well-differentiated squamous cells, you can like scrape those out. It's something that you would not do like in a cosmetically sensitive area. So like on somebody's face, like, wouldn't like, because it leaves more of like a circular scar. So like you're going to scrape it away, and where there was skin cancer, there is now a scar that is in like the shape of the thing that you scraped. And this talks about cure rates are 90 to 93, and then higher in experienced hands. And it really does have to do like how the tissue feels, and like when you know that you've scraped away enough, because biggest downside of doing this scrape and burn is that you don't send off tissue that's like, hey, good news, you got it all out. You just kind of scrape until you get to the normal skin, and then you say, okay, well, we're going to watch this, and you're going to be coming back for your skin check because that's what's recommended. You come in 6 months, we'll look at it again and make sure that it doesn't look like these things are growing back. And the good thing about scrape and burn base or ED&C is that you're doing it on the types of skin cancer that are the not aggressive kinds. So like superficial basal cells. So I tell people, like, let's say there was like a cell of the basal cell that escaped the scraping and it grew from there. And you're like, oh, that it came back or it grew more. It's not going to spread. So like, it'll just be, you'll see a little pink, scaly thing right next to where the scar is, and they'll be like, oh, there's more basal cell there. So you can either scrape that away more, or sometimes after you've tried the ED&C once and it's come back, like then you'll do an excision at that point to like get the margins and like get it out. But typically, like, that's why for these ED&Cs, we don't do those on like the more aggressive kinds of skin cancer.
Mhm.
We'll do it on the ones that are like the more like the cavity, and the really good thing is that the procedure takes only a couple minutes. It's minimal downtime. It's a scab. There's not stitches that can pop open. So it's much easier recovery from doing something like that. And sometimes people, again, you're higher risk, like once you've had one to get other ones. And so if this is like your, 10th skin cancer,
Yeah.
then you don't want to keep having things cut and cut and cut. And so sometimes the scrape and burn is like a good option, especially if they're like lower grade or like less aggressive kinds. And if you're catching them early and they're real little, it's easy to just do a little scrape and then say, okay, we're going to keep an eye on this and make sure it doesn't grow back.
Yeah.
And 95% of the time that's the case. So, and then creams, you can do creams. There is a topical chemotherapy medicine called 5-fluorouracil, and then there's another one called a imiquimod, and they're very different in how they work. A imiquimod is more like of an immune stimulatory effect, so sometimes that can make people feel like systemically kind of ill, like flu-like symptoms almost. The 5-fluorouracil is directly like cytotoxic to the cancer and precancer cells, and so
Mm.
it creates more like wounds, like scabby, crusty. Sometimes, you may know somebody that has done the chemo cream to treat precancer or actinic
Yeah.
keratosis, like on their face, and it'll look like all kind of like raw, yucky. But then that heals because you do it for like a certain defined amount of time. So the 5-fluorouracil usually is like a couple weeks. Twice a day. And imiquimod's a little different. You got to go a little bit longer. And it depends on the study that you look at, but cure rates can be up to 80 to 90% if you pick the right type.
Mm.
But again, with the chemo cream, you don't get like the histologic confirmation, like, hey, yes, it's all gone, you got it out.
Right.
So it is a little bit of a concern there, where it's like, okay, did you clear the top, but there's more underneath that's not gone, and so. We'll do it sometimes for people, again, if you've had like a bunch of them, or if it's really early, or if you're just unable to undergo, surgery. But it's kind of like more of a special case where we'll say, okay, we'll try treating with the cream. A lot of people don't like the cream because it sort of prolongs the healing time, and the fact that you got to do a imiquimod for 6 weeks, like that. It's just it's a scabby, yucky, inflamed place for like a long time before it heals. And so typically it's just easier to like come in, scrape it out, and then it's gone. So,
Yeah.
but it's patient dependent. So
Okay.
there are certain cases where creams can be helpful. Any questions about that before we go on to the melanoma? Because so melanoma is obviously, it's a little bit of a different scenario. It is the kind of skin cancer when you hear like, oh, so and so died from skin cancer. That's typically melanoma.
Mm.
They can spread. They do spread sometimes if you, again, don't catch them early. So this is a big thing. Like, early detection is the way to get good outcomes with melanoma. So these are kind of the things to look for about this ABCDs. So moles that are asymmetric, moles that have border irregularity, So you can see here where there's like that irregular scalloped border at one edge. The colors is variable colors inside. Um, and then diameter greater than pencil eraser, and then evolving. And that's the big thing that I tell patients to look
Yeah.
for, because it's tough. Like if you look at all of your moles, like there's probably some that are asymmetric. There's probably some that have some border irregularity. But the big thing to look for is changes. So changes in color and changes in size or shape. And I tell people, if you get a mole and it's growing a little like tail to one side, like that's something to call about. But these are kind of the things, the screening things to look for melanoma. Um, and it's so it is possible. So melanoma most commonly is found on the skin, but you can get melanoma inside your mouth. You can get melanoma in the back of your eye. So particularly for people who've had melanoma, I always tell them to make sure their dentist is aware, doing like good like screening in the mouth,
Mm.
and see an eye doctor to look in the back of your eye. You can get, vulvar melanomas can happen. You can get melanoma on the bottom of your foot, under nails, that kind of a thing. So it's good to like be aware and be looking at those things, particularly with a personal history of melanoma. Um, and it's one of the most common cancers in young adults. Again, men more than women, again, probably just because of sun protection habits there. Um, and then the it's interesting because the number of melanoma cases is increasing. Um, and it's most rapidly increased cancer in Caucasians. But the mortality has been stable. And recently, with like the newer immunotherapy type treatments, it's
Mm.
actually been improving, which is great. But we're diagnosing more melanomas. Um, it has a much higher risk for mortality than the basal cell squamous cell, so the non-melanoma skin cancers. And the most important predictor of the mortality is the what's called the Breslow depth. So like how deep down into the dermis does it go? Um, and they do like a measure under the microscope where they look at like what's the millimeters of Breslow depth. And the deeper the Breslow depth, the higher risk that it can spread. Um, let's see, represents less than 5% of all skin cancers, and the lifetime risk of somebody developing melanoma is around 1 to 3%. So again, early detection is the key to good outcomes. There is a diagnosis called melanoma in situ. So again, that in situ means it's only in that epidermal layer, so it hasn't technically invaded down into the dermis. Often on sun damaged skin. Um, if you can find it this early and you treat it and you take it out, the overall survival rate is great. There is really, you know, if, if it hasn't invaded down into where the dermis, where those lymphatic vessels are, like it doesn't have access to be able to like spread to other parts of your body. So if you can really treat a truly in situ melanoma and get it out, then then that's good. It doesn't have the risk for spreading.
Yeah.
Um, so patients with history of melanoma in situ have really close to the same survival as somebody who's never been diagnosed. Um, but it is, again, risk factor for developing an unrelated, like a melanoma somewhere else. And so that's one of the really important reasons to be coming for your skin checks. Isn't necessarily because the specific melanoma in situ is going to be a problem down the road, but once you've had one, now you're higher risk for another one, and you don't
Yeah.
want to miss one. And now, it's invasive and has access to those lymphatic vessels and could potentially spread down the road. So a lot of what we do when people come back is we do full body skin checks every time to see, like, is there something new somewhere else? Um, and then it's just a marker of significant lifetime sun exposure, of kind of your cumulative amount. So people who have outside jobs, that kind of a thing, just get a higher risk for melanoma. Um, so again, more of a stronger genetic component than the non-melanoma skin cancers. So family history is a little bit more important to note. Again, fair skin, red hair, inability to tan. Um, intense intermittent sun exposure, history of tanning bed use, and we'll talk about that, how that increases your risk. And then people with more than 100 moles or more than 5 atypical moles. And then again, if you've had a history of melanoma, you're higher risk to get another melanoma. We kind of talked about this already about like, well, what do you look for? It's important to note that 20 to 30% of melanomas develop in an existing mole. So you have a mole and it changes. So that's only 20 to 30%. 70 to 80% come just out of nowhere. On normal skin, you'll all of a sudden get this spot and you're like, oh, that's a black spot on my skin. So like, just because it's a mole that's been there a long time doesn't mean it's okay. But just because, it's like, it's not, you can't just take off all your moles and then you don't have a risk for melanoma anymore, because
Yeah.
most of the time melanoma comes from just nothing. It comes all of a sudden, what we call de novo. So like, it's not a mole that changed. So it's something to be aware of. So it's important to keep an eye on your skin. So monthly self-skin exams. If you notice a mole that's changing, moles that bleed, that can be a sign, again, the bleeding. Moles that are getting darker, changing colors, call your dermatologist to get an appointment, have it looked at. Because when things are caught in the early stage, it is most likely treatable and you're fine. And it, does have a higher risk spread once it's down deeper. So if you wait, then that's when it can become, more likely to be a problem.
Hmm. You mentioned getting in with the
Yeah.
dermatologist.
Uh-huh.
Does that typically take a referral? Are you guys
Yeah.
doing
So
self
that's yeah.
referrals?
So we currently are not requiring referrals for patients. Um, to make an appointment, you can just
Okay.
call or go to our website.
Okay.
Um, and you can, request an appointment that way. You don't have to have a referral right now.
Got it.
Um, And then there are different subtypes of melanomas. I know I talked about you can get it, under your nail. So there's a picture of a melanoma under somebody's nail. There's a picture of a melanoma on somebody's heel. A lot of times when I'm doing skin checks and I'm looking between toes and on the bottoms of feet, and people are like, well, I didn't get sunburn on the bottom of my foot, which you
Yeah.
didn't, but still it can happen. Um, so, be aware. And when you do look yourself over, try to do, use mirrors, look at, do like a monthly kind of skin check, look between your toes. People don't look between their toes. And so that's why I tell people, I'm here to be your toe checker. Like, we're going to check it because if you don't look, you don't know, and so, it's luckily not that common, but if you have something and you think, oh, I have this weird bruise on the bottom of my foot and it's just not getting better, have it checked because,
Mhm.
those things can be melanoma. So, treatment, most commonly wide local excision, 1 centimeter margin tends to be the standard. If it's deeper, then sometimes they'll take even more than that. Um, and they'll need to do a sentinel lymph node, or they'll sample your lymph nodes. And typically we send people to the surgical oncologist for that. We don't do that here in the office, this lymph node sampling. So if your Breslow depth is closer to 1 millimeter, that's when we say, okay, you probably need to see the surgical oncologist. So it's about between 0.75 to 1 millimeter Breslow is when we'll send people to have their lymph nodes checked. And then it's possible to do Mohs surgery for melanoma in situ and thinner melanomas. Some places do that. And then systemic therapies, again, talked about like with the development of the immunotherapies and things like that. Now people are really doing much better. It's been a really huge game changer for melanoma, and particularly metastatic melanoma. It's amazing, like just even, again, changing monthly. Like there's a new melanoma drug that's coming out very soon. So it's a great thing that is sort of rapidly developing. And there's lots of good, much better therapies than there used to be. So, again, with the Breslow depth is the best predictor of long-term survival. Um, And then we already talked about, if it's about zero point 0.8, so 0.75 to 1, that's when you need to see the surgical oncologist to see whether or not you need to have your lymph nodes sampled. Ones that are ulcerated or have increased what are called mitotic figures under the microscope. So mitotic figures just means that the cells are dividing more quickly. And then I just wanted to have like a little note about Merkel cell carcinoma. This is the skin cancer that Jimmy Buffett, unfortunately, recently passed away from. These are very rare, about 3,000 ish in the United States per year. So much less common, luckily, because they are one that are even more dangerous than melanoma. They grow quickly. They or tend to be like red or pink, and you'll get this like little red or pink bump that doesn't really hurt but doesn't go away. They tend to develop on the head and neck, but they can come anywhere, and they're usually in an area where you've had a lot of sun, and it's much more common in older people, but it can be a little bit scary because like this picture of this on this person's eye, like that just kind of looks like a sty, and you might think, oh, I have this sty that's like not going away. But again, things that have been there and aren't healing for, a couple months, like that's probably something to have examined. But again, much less common. I think I've probably diagnosed 2 of these in my 13 years of doing this. So, not common, but something to just be aware of if you like have a spot and you're like, this isn't healing. So just quickly about pre-cancers. So actinic keratoses are really common. It's estimated that 15% of the United States population currently has at least one of these. Usually they're on the face, head, neck. Arms is another thing. And it's roughly estimated about 1% would develop into squamous cell. And they kind of feel like these like dry patches. So if you're like, I have this like dry patch here and it like always stays dry, no matter how much lotion I put on, it's like still dry and flaky. That is something that's typically a precancerous. Now, if you're like, ooh, and it hurts and it feels like there's a piece of glass in my skin, well, that's when you need to call us. The treatments, you can freeze them. A lot of time we do that for the most part. You can do some topical creams and things for the pre-cancer stuff too, like we talked about with the 5-fluorouracil, the imiquimod. This is just more pictures of those pre-cancers. They're like little gritty kind of macules that come. And then there are sort of a version of what they consider like a precancerous mole or dysplastic nevus. And those are sort of graded and like how atypical are there. So there's mild, moderate, severe. And there's debate about like, would a mildly atypical mole like go on to change and then become a melanoma? And it's really thought that doesn't really happen. Severely atypical, that's when you get a little bit more worried and you go back and you like take a margin to make sure that that's all gone. But again, from the before, like 70 to 80% of melanomas are not coming from a mole that's there, they just come from nothing. So, it's you want to be aware of moles, particularly the moles that change. And these atypical moles put you at higher risk for melanoma. But not necessarily that like every atypical mole is going to change and become, a skin cancer.
Would you remove these just to play it safe? I mean, there?
So that's a good question. Typically mild, no. Moderate, it sort of depends. Usually when we do the biopsy, we'll like just remove the whole mole. So when it comes back moderate, you're like, hey, good news, it's gone anyways.
Right.
With severe, that's usually when they'll go back and say, hey, you should go back and like cut it out and like make sure the margins are clear. The biggest concern there is, there's one person that might call it a severely atypical mole. Another pathologist might say, oh, well, I think that fits the criteria of being a melanoma in situ, because there's not as good like defined criteria for like, where does the transition take place? Where, okay, this one's severely atypical, but this one's now, melanoma. So if it's severe, it's like close enough, like it's like better to just have those be taken care of and gone. And then this is where it gets tricky. And I tell people, this is why I have a job, because There are benign things that come up all the time on your skin, and they're nothing to worry about. Seborrheic keratoses is one of them. And they come, I tell people, they come as time goes by. Um, and they can look crazy, and they have all the ABCDs. And a lot of times people come in and they're like, I think I have a melanoma because it's asymmetric and the borders are irregular and it's different colors. And it turns out that it's one of these seborrheic keratoses. And so I'll show you a few pictures. But one of the things that you can try to determine is if they're like kind of scaly or dry on top, and you'll be like, oh, like this is like this, I could almost like pick this thing off. A lot of times that's the seborrheic keratosis. There's a big genetic component for, like, most people get like some, but like some people are just unlucky and they get a bunch.
Mm,
But they don't turn into skin cancer. So they're totally fine to leave alone. They can be irritating and they can get itchy, and they'll be like in the brow line and places where they like get rubbed. And if that's the case, then we can freeze them to try to get them to go away. But they're not dangerous. So, that's great. But
yeah.
again, if you're ever unsure, it's best to like have something looked at. But
Hmm.
they can come up out of nowhere, and people will be like, I woke up today and this is here and it wasn't there yesterday. And it's like this big irregular brown thing. So these are all seborrheic keratoses. So you
Okay.
might look at these and be like, oh, look, ABCDs right there. But because they're not a mole, they're a keratosis, they don't follow the same rules. So again, this is why I have a job, because it's difficult to tell. And people say, oh, how do you know the difference? It takes a lot, it's a lot of school, a lot of looking at stuff to figure it out. But if
Yeah.
ever you're concerned, then it's best to like call and have it looked at. But just because something is new and brown doesn't necessarily mean that it's a melanoma. So again,
Yeah.
you can kind of tell in this top picture where it's like kind of, they get like this like scaly, rough top to them. They almost sometimes look like warts. But these are all nothing to worry about, luckily. Okay. Questions about any of that? We'll talk about screening, getting skin checks. So,
Hmm.
who needs to get a skin check? So, this is like one of the like interesting questions that we debate and deal with all the time here,
Yeah.
about like, well, like, should we be screening everyone? Like, who needs to come in? So, the general guidelines for like the US Preventative Task Force for like what should be screens, like the general population is not recommended to get a skin cancer screening. Now, if you are higher risk for skin cancer, then yes, you should get screened. And the difficulty there is, okay, if you have a history of blistering sunburns, then you should get screened for skin cancer. Who doesn't have a history of blistering sunburns? Like, I mean, a lot of people have
Yeah.
that. And if you've had 5 or more blistering sunburns between the ages of 15 and 20, you're increased risk for melanoma by 80%. So,
Wow.
yeah. So it's so important, especially in young people. Like kids, if you had a blistering sunburn before age 5, it doubles your risk for melanoma. One sunburn.
Wow.
So the prevention is so important. We're going to talk about that too. But so history of blistering sunburns, you need to get a skin check. History of tanning bed use, unfortunately, lots of people. Hopefully now the word is out that like this is a carcinogen. Do not use tanning beds.
Right.
But lots of people have used tanning beds in the past. Tanning bed use before age 20 increases your risk for developing melanoma by 47% and increases with each time you go. So like
Right.
it's such bad UV exposure. And then I just thought this picture was funny with the baby oil, because a lot of people, like so many of my patients are like, oh, we did baby oil and iodine. And people just used to like cook their skin.
Hmm.
So, those folks are the ones that we're seeing now when we're cutting things off. And so if you use baby oil and iodine, you probably should get a skin check.
Isn't there like a fact about how many sunburns the equivalent of using a tanning bed is? I mean, is there
There may be,
intensity
but yeah,
being
as I say,
so
it's
much
it's it's
more?
a lot. I mean, like it's tanning beds is particularly like each time you get into a tanning bed, it increases your risk for melanoma.
Yeah.
So it's such a bad thing. People think, oh, I'm going to go get my base tan, and then I won't burn when I go to the beach. Like that is not a thing. That does not help
Mhm.
you. Do not get a base tan. Tan skin is damaged skin, is what we say. So any tan is bad. The only good tan is the tan that comes in a bottle, and that's fine to do. by the way.
Okay.
So self tanner is good. The but yes, so like is tanning beds in particular have such higher UV exposure that it's each time you get in, it's bad.
Yeah.
Um, and then again, so we talked about family history a little bit, but 5 to 10% of melanomas are familial. And so if you have a family history of melanoma, other cancers that can sort of be grouped into some of these other syndromes, pancreatic cancer is one. So if you have a strong family history of pancreatic cancer, that can increase your risk for melanoma. And then if you have a first degree relative that has had melanoma, you should definitely get a skin check.
Yeah.
And then oncogenic mutations. So these are the ones that are specifically the CKN2A, MITF, and then the BAP1 mutations. Those specifically put you at higher risk for melanoma as well. There's a little bit of controversy, the BRCA1, BRCA2, whether or not that puts you at higher risk for melanoma or not. But probably a good idea to get a skin check and baseline. And then you can always talk with the dermatologist at that point. What are your risk factors? Do you specifically need to be coming in for skin checks? Sometimes I'll have people come and they'll come like every other year, or they'll come every 3 years, just to like have somebody to call if something were to come up. Because a lot of it's like we say, okay, you need to like call us if something's bleeding, call us if something is not healing, but if you don't have somebody to call and you have something bleeding,
Right.
then you try to get in and it's like, oh well, we can't see you until the spring. Like, you
Right.
want to be able to have somebody to come in. So I do have patients that sort of maintain being established by coming every couple of years,
Yes.
if they're low risk. Muir-Torre syndrome is another genetic thing that puts you at high risk for sebaceous carcinomas, which we didn't talk about. But that's another type of a skin cancer that can be a little more aggressive. So that's a good one to be aware of. Bloom syndrome is something that puts you at high risk for squamous cell. There is a condition called basal cell nevus syndrome, and that's the one that like basal cells specifically can be a problem. Xeroderma pigmentosum, epidermolysis bullosa, and Fanconi's anemia all have high risk for squamous cell as well. If you have some sort of genetic cancer syndrome,
Yeah.
there's a thing called Li-Fraumeni that can have high risk for skin cancers. It's best to talk with a geneticist, and they can certainly steer you in the right direction about are you at higher risk? How often should you be coming, and all of that. And then just a quick word on prevention. I talk about this every day, all day.
Yeah.
So protecting yourself from the sun. I mean, this is a huge, huge, huge thing that is a risk that you can mitigate, because UV exposure creates DNA damage in that epidermal layer, which forms mutations in your DNA, which then progress and can become skin cancer. So
Hmm.
you really, really, really want to protect your skin from the sun. These are just two interesting pictures. One just showing kind of where somebody, has had no sun damage, where there's nothing, and then, all of this, I would refer to as like actinic damage, but like certainly high risk for skin cancer in those areas. And this other picture is a lady who was a truck driver, actually. And so half of her left side of her face has all the sun damage, and then her right side of the face has none, basically. So just kind of shows you the effects of the sun, which I'm sure we all, are aware of. But protecting yourself from the sun. So you want to do at least SPF 30 broad spectrum sunscreen. So you want to say broad spectrum. And most of the like generic brands that you are aware of, Coppertone, Banana Boat, Neutrogena, those are all broad spectrum. But at least SPF 30. If you are going to be like at the lake or at the beach, 50 is the best. Over 50 doesn't really give you much additional benefit,
Yeah.
because really you should be reapplying. And that's where people get into trouble, is they don't reapply their sunscreen as much as they should. So it's at least every 2 hours. But if you're sweating, you're in the water, like you need to do it more often, because while sunscreens say they're water resistant, like after you get out of the water, you have to put more sunscreen on. And some of them, they'll say water resistant 80 minutes, which means after 80 minutes, you have to reapply. Some of them even say 40 minutes water resistant. So after 40 minutes, you have to reapply. So look at the label. And then sun protective clothing, I cannot preach that enough. Sun protective clothing is great. It doesn't wear off. It's not something you have to rub all over. You just, it can be, people don't like it because they feel like, oh, I'm going to get hot. I don't want to wear long sleeves when I'm at the beach. But the
Mm,
fabrics that they make them from now are really great. If you get them wet, they stay wet and they actually cool you off.
mm.
Sun protective clothing, hats, sunglasses. Again, you can get melanoma in the back of your eye, so it's great to like protect your eyes from the UV. Usually people don't put enough sunscreen on, so they say about 1 ounce to like your exposed areas. So you typically like arms and legs. But
Yeah.
really trying to cover up, staying in the shade, and like not being out right in the middle of the day, it makes a difference. The UV rays are more intense right in the middle of the day. So
Real quick,
yeah,
I know there's kind of a hot topic just as far as um, the chemicals in
yeah,
sunscreen,
yeah.
um, endocrine
So
disruptors,
mhm.
mineral sunscreen. Do you have any input on whether people should be buying specific brands, or is there any guidance there?
Yeah. So I'll go. Well, it doesn't really matter, but I'll go back to this slide. Um, the chemical sunscreens, those are like your avobenzone, oxybenzone, all of those.
Yeah.
Really, like, there's not enough evidence to say like whether or not like is that bad to like rub chemicals all over your body all the time. Certainly, we know that like the UV exposure is bad, so we know that that causes skin cancer. Um, so, I tell people, like, if you are concerned about that, do a physical blocker, like do the zinc oxide, do the
Yeah.
titanium dioxide. They're a little bit harder to rub in, um,
Right.
but they do work and they work great. Zinc oxide is a fabulous sunscreen.
Okay.
It is sometimes, again, better with the clothing. So like I
Mhm.
personally do a lot of sun protective clothing because I don't love rubbing chemicals all over my body all the time. Like I get that. I think that that's a very good thing to at least be aware of.
Yeah.
But if you do sun protective clothing, then you don't have to do that. Um,
Exactly. Yeah.
but the physical blockers are good. A lot of times, like that's the one that's like in the baby sunscreens or the mineral based sunscreens, and those are good. Good alternatives if you don't want to do the chemical sunscreens. I will tell you, I do a chemical sunscreen on my face every day. That's because it rubs in better, and I do think that it's in limited areas. Like I think it's safe. Like I said, there's not great evidence that it's not really at this point, or at least enough to make me stop doing it.
Right.
Um,
And there's tinted moisturizers for women that want a little bit of color, maybe
yes, yes, a
in
lot.
foundations, and obviously, wide brimmed hat and the sunglasses, and
Yeah.
you know, fishing shirts, those more
Hmm.
looser outerwear for beach use. Those can be
Yep.
really, an easy thing to
Yeah.
throw on. So,
Yes. Um, so yeah. So that's all. Those are all good points, and I totally agree with you on all of that. So, all right. And so this is just saying, you definitely want to do good sun protection, and that's really the bottom line. And that's it.
awesome. Well, we so appreciate you sharing your expertise with us.
Well, you're
Obviously, we
very
all
welcome.
have skin. It's the largest organ in the body, and we're always looking to better protect it, especially here, in the South where we get so much sun most of the year. So, really
Yes.
appreciate you giving us some of your insights, and hope this can help a lot of people protect themselves from skin cancer. All
Yes.
right.
Thank you.
Yeah, of course. We like to end our series with an inspirational quote. We definitely like to just inspire people to continue to be really vigilant about their own health. Um, this is a quote that LC sent me. Do not be dismayed by the brokenness of the world. All things break, all things can be mended, not with time, as they say, but with intention. So go, love intentionally, extravagantly, unconditionally. The broken world waits for darkness for the light that is you. And that is from L.R. Nost. So just a good reminder to continue to be a light in the world and spread health and positivity. We'll look forward to seeing everybody back for our December series about self-care during the winter holidays with Julie Humphreys, with another one of our local healthcare centers here in Greenville. So thank you so much, Dr. Scharf.
All
Really
right. Thank you.
taking the time.
All right.